My name is Bill Osich. I'm from the School of Earth Sciences, and I'm this academic year, I'm chair of the Emeritus Academy Steering Committee. And welcome to the first Ohio State Emeritus Academy meeting for 2022. Before I talk today, I want to have a brief business meeting and make a few announcements for the spring semester, and during which we will both complete the activities of the 2021-2022 academic year and begin planning for the 2022-2023 academic year. Later this month, you will receive 3 different messages from the Academy. First, there'll be a call for new members. The deadline is March 4th. And I urge you to contact all of your Emeriti colleagues who are not members of the Emeritus Academy and encourage them to apply. And we're hoping for a lull in COVID next year, and we can get back together again in the faculty club and renew that fellowship that we have there. Second, there'll be a call for new members to the Emeritus Academy Steering Committee, and please nominate yourself or someone else. Members of the Emeritus Academy oversee all activities of the Academy, including, among other things, the review of grants and the review of new member applications. And third, we'll have a call for next year's Emeritus Academy lectures. Again, please nominate yourself or fellow Academy professors. Your input is necessary to continue our tradition of excellent talks that span the academic breadth of the Academy. Does anyone have any questions about any of those items? Our next meeting will be Wednesday, March 2nd, and our speaker will be Richard Green from the Department of English. His presentation is titled Fairy Tales and Tales About Fairies in the Middle Ages, which sounds like it'll be a very enjoyable presentation. I'm looking forward to it. Also, I'm very pleased to announce that Executive Vice President and Provost Melissa L. Gilliam will address the Academy at the beginning of our March meeting. During the talk today, please mute yourself. And after our talk, I will attempt to monitor questions that can be asked either in person or in the chat feature of the Zoom. Now I am pleased to introduce Michael Griever, who is an Academy Professor of Hematology. Dr. Griever received both his BA and MD from the University of Pittsburgh. Following his internships and residencies, beginning in 1978, Dr. Griever has spent the majority of his time at Ohio State University in various positions in the medical school, including hematology, oncology, physiological chemistry, pharmacology, and internal medicine. He has been the Charles A. Doan Chair of Medicine and the Bertha Bornacle MD and Philip Perrine Chair in Cancer Research. From 2000 to 2017, he was chair of the Department of Internal Medicine. And from 2001 to 2017, he was the Associate Dean for Medical Services in the College of Medicine. This is just a brief listing of an amazing variety of administrative positions and professional service contributions that Dr. Griever has made. He's also received numerous awards throughout his career. Most recently, he was awarded the 2002 Ohio State University Distinguished Scholar Award. He received the Hench Award from the University of Pittsburgh School of Medicine for a medical school alumni. He received a 2013 Chancellor's Medallion from the University of Pittsburgh. In 2018, he received Outstanding Service to Cancer Development from the NIH, and also from the NIH in 2018, an Outstanding Service to the Next Program and the International Investigational Drug Branch Steering Committee. Dr. Griever has an extensive history of funding and publications, and suffice it to say that his publications cover a wide spectrum of medical science topics, including, of course, the topic of his talk today on hairy cell leukemia. So it's my distinct pleasure to introduce Michael Griever, and his talk today will be The Legacy of the Ohio State University and Hairy Cell Leukemia. Michael, the floor is yours.
Thank you very much for this opportunity to talk about the role that Ohio State University has played in the study of a rare adult leukemia and the progress that's been made. And one of the amazing things about this university is the tremendous cooperation and collaboration that enabled this to happen. This paper, which was written by one of my former professors, Dr. Broccoli, back in 1958 with her colleagues, Drs. Wiseman and Doan, was one of the initial descriptions, a very comprehensive description of this entity. And it was called leukemic reticuloendotheliosis because they really, frankly, didn't know the cell of origin. And they thought that it came from the reticuloendothelial system, but she described all of the manifestations of this disease in this one report. Dr. Broccoli was really an amazing person. She graduated from medical school in Lima, Peru, and won a scholarship to study hematology abroad. She selected Ohio State because of the eminence of Drs. Doan and Wiseman. And when she came here from Peru, she was so successful as a trainee that she became the chief resident in the Department of Medicine. And the thing that was remarkable at that time, she was the first woman physician to be a chief resident in a major academic medical school who was foreign trained. And she stayed at Ohio State for the entirety of her career and did tremendous things in terms of the science of leukemia as well as treating patients. This picture were her collaborators, Dr. Doan on the left and Dr. Wiseman on the right, and they were internationally recognized for their expertise in leukemia as well. So Ohio State very early on became a beacon of leukemia research. And I was fortunate to come here in 1976 and was working in the lab. And I had tremendous help from the Department of Physiological Chemistry, as well as the College of Pharmacy. And that, in conjunction with the experts in the Department of Medicine, enabled me to participate in the research with this rare leukemia. This is a picture of the leukemic cell in patients with hairy cell leukemia. And I think from its morphology there, you can see very readily why it was nicknamed hairy cell leukemia, but that nickname has become a permanent description of the disease. This disease is found in many parts of the body, but it's predominantly located in the spleen and the bone marrow, and these cells circulate in the peripheral blood. Dr. Broccoli's description shows some very interesting things about this disease. One of the entities, or one of the aspects of this entity that are as yet still not defined, why there's such a male predominance of 4-to-1. That's never been explained. The median age is 55, but we've had patients here at Ohio State as young as 21 and as old as 99 with this disease. The symptoms are related to fatigue and infection. It used to be that most of these patients all had an enlarged spleen, but now that the disease is identified a little bit earlier, many of the patients present with an enlarged spleen, but not nearly to the extent when Dr. Broccoli was seeing those patients. Because the bone marrow is involved, the blood counts are low, and the diagnosis is made by looking at a blood smear and also by doing a bone marrow. Recently, the clarification of the classic form of this disease is enabled by using flow cytometry to show that these specific markers are present on the leukemic cells. That confirms that the appearance is consistent with the classic form of hairy cell leukemia. There's also an even more rare form of a variant of the disease that we'll mention briefly a little bit later. Leukemia, this hairy cell leukemia, the patients are very susceptible not only to bacterial infections, but to life-threatening opportunistic infections and viral infections. Shingles is a very common problem for these patients because of their impaired immunity. One of the things that's very dangerous is if the patient with hairy cell leukemia develops shingles. If they're not treated, it can be disseminated, and the disseminated form of this viral disease is fatal. There are many autoimmune aspects that are of tremendous interest in this disease, and then about 5% of the patients can actually have bone lesions. All of these were described by Dr. Bronkley in her classic paper from 1958. This paper was so heavily quoted that it actually became one of the top 50 manuscripts that were published by the journal Blood over the course of 50 years. And one of the things in 1984, if you could see the whole part of this slide, is it's incurable, and it was considered to be treatment unresponsive because the bone marrow is so heavily involved. If you use standard chemotherapy, the patient's blood counts get even much worse. So patients were treated by removing the spleen by surgery, but that was a temporizing measure because the median survival for these patients back in 1984 was just 4.5 years. And so most of the patients died from infections and cytopenias, which mean low blood counts and bleeding. And it's also been observed and confirmed that about 3 to 10% of the patients can have a second malignancy because of their impaired immune system. Dr. Bronkley described all of these. These three chemical structures were a very significant advancement in the treatment of this disease. I began my research with the compound in the middle, which is an irreversible inhibitor of a very important enzyme called adenosine deaminase, which is ubiquitous in the cells in the human body. We gave the first doses of the inhibitor of that enzyme. This compound called deoxycofurmycin was a irreversible inhibitor of that enzyme. And the slide to the left, fludarabine, is a similar purine analog. It does not inhibit adenosine deaminase, but we developed it here at Ohio State back in the 1980s, and it became the frontline management for another disease called chronic lymphocytic leukemia. We gave the first doses of this, and we published the first paper showing that this was effective in patients with far advanced drug-resistant chronic lymphocytic leukemia. The item to the extreme right, cladribine, or 2-chlorodeoxyadenosine, was actually developed by Scripps out in California, and it today is one of the more frequent, if not the most frequent, agent used to treat hairy cell leukemia. It's a little bit more challenging at times than penistatin, but both of them are equally effective. So the two drugs that are most often used to treat hairy cell leukemia in the current era are cladribine, which was developed by Scripps, and penistatin, which we developed. And the mechanism, they interfere with DNA synthesis, but there's a number of other mechanisms. But then there's different administration schedules. The cladribine is given in a very abbreviated course of therapy and is associated with really profound myelosuppression, because when this densely infiltrated bone marrow is hit by 5 days worth of therapy, there's often severe lowering of the counts before things get better. In contrast, we give the penistatin every other week, and that approach results in less infections, but it is a more protracted course of therapy. This is the chemical reaction where adenosine is irreversibly deaminated to inosine, and this occurs in every cell in the body. And penistatin is a very close structural analog to the transition intermediate state between the substrate and the product. And that's the drug that we call penistatin. What I did in the lab and in the clinic was we titrated the dose of this inhibitor of adenosine deaminase to make sure that we gave enough to inhibit it in the leukemia cells, but not enough to inhibit it in the rest of the cells in the body. And therefore, we used expertise from the College of Pharmacy and Biochemistry to help us define what was the optimal dose that would not produce excessive myelosuppression or bone marrow suppression, and which would be effective, but not as toxic. These are cells that I used in the lab at that time. These are cells from chronic lymphocytic leukemia, which is a much more common form of adult leukemia than hairy cell leukemia. There's only, as I think I may have mentioned, there's only about 1,000 new cases of hairy cell leukemia identified in the United States every year. But chronic lymphocytic leukemia is much more frequent. It's one of the most common forms of adult chronic leukemia. But I used these cells in the laboratory to measure the inhibition of the enzyme and define what would be the optimal dose going forward, with a lot of help from the College of Pharmacy and the Department of Physiological Chemistry in the College of Medicine. So what this resulted in, Dr. Kraut and Dr. Bronkley and I conducted a study back in the 1980s, and we found that 87% of the patients that we treated with this schema with penistatin could go into a complete remission. And if you remember, they said that most chemotherapy would not work on this disease because the bone marrow wouldn't tolerate it. There were multiple other investigators who confirmed what we found. And one of the interesting things here is that those regimens that were heavily dosed with the drug had a lower complete remission rate. So this was an unusual form of treatment for leukemia where less appeared to be better. But we based this all on the biochemistry and the pharmacology before we embarked on this study. I had an opportunity to conduct the first randomized study between penistatin and a drug or an agent that was being used to treat hairy cell leukemia at that time called interferon. And so with the help of about 4 large groups in Canada and the United States, we were able to launch a randomized clinical trial in this rare disease. And I did this while I was at Ohio State University, and we were able to secure from Canada and the United States 356 patients with this rare leukemia within 3 years who needed therapy. And this shows on the left, we had 154 patients who were initially assigned penistatin, and the complete remission rate in this large group was at least 76%. Interferon had a complete remission rate of only 11%. So you might wonder, why do we even do this in the first place? Well, interferon was felt to be less immunosuppressive than these purine analogs. And so we had to do this study to show that there was truly a benefit. And one of the other things that we found is if you take a look at those 11 patients, or no, I'm sorry, the 159 patients started on interferon, if they didn't get a good response, we crossed them over, 86 of those patients, and we were still able to get a complete remission rate in about 66% of the patients. So we did a long-term follow-up on this, and we looked at 241 patients that were long-term patients who were on our study. We looked at 9 years. And the interesting thing is that the overall survival was projected to be 81%. And 67% of the patients out at 9 to 10 years didn't require more treatment. And if you remember, this is the same disease that had been adequately predicted to only have an average survival of about 4.5 years. So we really felt that the use of penistatin changed the natural history of the disease. And this all was led by the studies that we did here at Ohio State. This just shows graphically that if you follow patients out to almost 10 years, you can see that the survival was equal, whether you start on interferon or whether you start on penistatin. So some people said, well, maybe the interferon is just as good, but you have to remember that we rescued 66% of those patients. Otherwise, the curves wouldn't be overlapping. The other thing that's interesting here is if you drew this curve back in 1984, it wouldn't look like this. It would be much sharper decline in survival. This also shows that older patients didn't do as well as younger patients, but that is a complex statement that needs to be further explained. This is a study from England, from the Royal Marsden Hospital, and they looked at 185 patients with penistatin and got a complete remission rate of 82%. Cladribine, there were 82% of the patients were men again. The next slide shows penistatin and cladribine in their hands actually were identical and very close to the complete remission rates that we found here in the United States. So it was nice to see the confirmation from such a prestigious hospital in the United Kingdom. This is an important observation because even though we get about 75 to 80% of the patients into a complete remission, 40% of them are going to relapse. And so you can see when you retreat them, as in item number 2, the complete remission rate goes down. And then when they relapse again, the complete remission rate goes down yet again. Nevertheless, the intervals between these courses and the patients are well and very functional during those times. So overall, we have improved. We may have to retreat patients, but their overall survival is improved. This slide shows that the duration, though, of these is not only fewer patients get complete remission, but there's a shorter duration. This is a study, again, from the United Kingdom. And so we realized that their statements from the United Kingdom were that it's really important to get a complete response if you want to have a durable remission. Patients getting a partial response don't get quite as much benefit. This is an interesting slide from their experience and has led to many important studies that are ongoing right now. And the curve that goes down rather significantly here is patients who were treated initially with either penistatin or cladribine. And then if those patients are treated during relapse, not with the same agent, but with the addition of a monoclonal antibody, rituximab, the duration of the secondary remission is markedly improved. And so the addition of rituximab, which is a monoclonal antibody directed against a marker called CD20 on the surface of these cells, markedly improves the response that you get with the purine analog. One of the concerns right now, however, though, is rituximab, when administered right now, will make it very difficult to get a good response to a vaccine. And so we've been very cautious about how we use this in the middle of the COVID pandemic. This shows a bone marrow that has residual hairy cell leukemia that may be visible by the light microscope, but the use of stains to bring out these brown cells shows how much disease is actually left. So the definition of complete remission is whenever you can't see any more hairy cells by morphology. But we're getting more sophisticated about getting a complete remission and then attacking the residual disease, because that may be important in terms of extending the duration of remissions. And that's where rituximab has really been an important player. And other monoclonal antibodies like rituximab are also being investigated. In 2008, I was approached by a group of patients who are very sophisticated, who have this disease, and they wanted to know, are all the questions answered with this disease? Because everybody was very excited by the fact that we changed the natural history and we could get people into remission, but all the questions weren't answered. And so they asked me to organize a group of experts, and I was very fortunate that I got experts from 28 different universities across the globe. We met in the airport in Chicago, and these are just a representative of a couple of the questions that we were trying to address. Should rituximab be added? Certainly, it looks like you get a much more durable remission. Should it be given simultaneously with chemotherapy, or should it be given follow-up? Should it be given at all right now in the middle of this pandemic? Although we weren't in the middle of the pandemic back in 2008, but these questions about how best to administer these two agents was important. And how important is minimal residual disease? With the advent of new agents, how should they be incorporated? So as a result of all these questions, we committed to meeting once a year, and we have met once a year to try and address the issues related to this rare leukemia, taking advantage of all of the intellectual prowess across the globe. So we realized that both penistatin and cladribine individually have changed the natural history of the disease. They now may live as long as they would have almost without this disease at all, but multiple relapses are going to complicate their existence. Novel therapeutic approaches are being investigated, and opportunities for managing infection and other complications still require attention. These are just an example of a number of new agents. This HA22 is an immunotoxin conjugate. It was developed by one of my colleagues at the National Cancer Institute. This B Raf inhibitor has really been a major advance, and this was initiated by discoveries from another colleague in Italy, Dr. Tiacci. There's other inhibitors of important targets. Bruton tyrosine kinase has been very extensively described here at Ohio State University in these B-cell malignancies. Doctors Bird, Wyack, and Rogers have done enormous work in moving ibrutinib up from an investigational agent to being the frontline therapy for many patients with chronic lymphocytic leukemia. And if you remember, we established that fludarabine was the frontline management that stayed there for decades until investigators here at Ohio State University identified this new important pathway. And this all happened right on this campus. And so innovative therapies for these chronic leukemias is so important. And the collaboration of investigators here on this campus has really been a leading force in developing therapies for this group of hematologic malignancies. Then the combinations are undergoing extensive investigation here, as well as other places. This is a paper that was published in the New England Journal of Medicine by one of my colleagues, Dr. Tiacci, and he identified that a mutation of the B Raf gene was present in almost 100% of the patients with this rare leukemia. And this became important not only in further defining classic hairy cell leukemia, but also serves as the target. And he conducted, along with a number of other investigators, we participated in this as well, where we used an inhibitor of this mutated target in patients with relapsed and refractory hairy cell leukemia. And we were able to get remissions with a single agent in about 40% of the patients, and improvement, though, in probably closer to 80% of the patients. But this agent is now called vemurafenib, is now being combined with rituximab. And so there's a lot of work that still needs to be done. But we're participating, whether the studies are started here or whether they're started somewhere else. We try and be a part of all of them. This is the pathway that was very heavily investigated here by Drs. Bird, Wyack, and Rogers, the BTK pathway. And this is important for promoting the survival of leukemic cells in chronic lymphocytic leukemia and lymphomas. We conducted a study here that was National Cancer Institute sponsored, and it was led by Ohio State, involved 5 other universities. And it was an oral drug called ibrutinib, and it disrupts that B-cell pathway. And it had been approved for other B-cell malignancies, but it wasn't approved for hairy cell leukemia. It's interesting that a lot of the agents that are effective in chronic lymphocytic leukemia often have benefit for patients with hairy cell leukemia. So we initiated this multi-site study sponsored by the National Cancer Institute. And the primary objective was to look at the overall response rate. The study opened in 2013, and we were looking for patients with relapsed hairy cell leukemia or refractory hairy cell leukemia, people who hadn't benefited by the frontline therapies that I've previously described. And we were also looking for patients with the variant of hairy cell leukemia, which is a very dangerous, non-responsive form of the disease. And so we were looking for these patients. And since the other agents that I talked to were so effective, we had a hard time finding people that were non-responsive. But eventually we found about 37 patients in 5 universities. And Dr. Rogers published the results of this pivotal study in 2021. So these patients, you can see here, they had a lot of prior therapy. Some of them had up to 12 prior therapies. 35% of them have had their spleens removed. 92% of them had been failures on cladribine, 32% on penistatin. And so they were very heavily pretreated. The variant, so both hairy cell leukemia that had not been responsive and the variant were the patients who Dr. Rogers studied. And it was multi-institutional, and she led this and published it in 2021. Actually, it was selected for the front cover of Blood. And here you can see that the best response in these heavily pretreated patients was 54%. And even though 7 patients got a complete remission and 13 patients got a partial remission, stable disease was another important feature of this because the patients were doing extremely well. And if you look at these 2 slides, you can see that even out to 5 years, patients are still stable, even though they may not be in a complete remission. So this inhibitor of BTK called ibrutinib has a lot to offer. Now, the next question is, would we do better if we added another agent to this? And so one of my patients that I'm following right now is completely functional, and he's been on this therapy for 5 years, and he works and is very, very productive, and he's totally asymptomatic. So he's not in a complete remission, but he's very, very stable at this point. So the overall response rate to the purine analogs that we talked about initially is 75 to 90%, about 40% of the patients relapse. The key thing, though, from the patient's perspective is that they can lead a near normal lifespan. And also, while they may have multiple relapses, we do have agents to treat them that have been developed here at Ohio State and other places in the world. So we're willing to bring these things no matter where they come from. Combination strategies are under development, and there's hope and progress that really has come out of working as a team, largely on this campus. So we talked in 2008 about the meeting we had at the airport in Chicago. So we decided we were going to set up centers of excellence in North America, Europe, Israel, and Australia. And we've had international meetings in both Europe and the United States. COVID has interfered with our meetings recently, but we've been conducting them by teleconference. So the Hairy Cell Leukemia Foundation and the Hairy Cell Leukemia Research Consortium, which are both agencies that are led by patients, have worked with other research foundations to increase research support. And so we published in 2017 the recommendations and guidelines for how you manage these patients. And we had agreement with 28 different universities to follow these recommendations. We also published a paper this year on how you can deal with patients during this COVID pandemic, and international participation in individual patient case reviews are associated with consultations. So we're very careful about not trying to do long distance medicine, but when doctors who have not had as much experience call and ask for advice, we try and put together an international meeting online to review some of the data, and we then can share that information with their treating physicians. In 2020, I organized a meeting at the American Society of Hematology to talk just about the challenges of infection in this disease. So we're trying to develop new webinars for physicians and patients to educate them about this rare disease. In 2008 and 2009, we put together a website for patients, and we keep that up to date. Research support. In the early 1980s, mid-1980s, most of the research came from patients who contributed $20,000 to $100,000 to their doctors to do local research. In 2017, I established this peer-reviewed process because we wanted to make sure that the research that was being done had a good rationale and had accountability for how the funds were spent. So in 2017, the Hairy Cell Leukemia Foundation cooperated with the SAS Foundation, and they awarded $2 million over a 5-year period to investigators who were focusing their research on hairy cell leukemia. Just recently, the Hairy Cell Leukemia Foundation has been working with the Leukemia and Lymphoma Society, and they've really upped the ante. So they're now supporting $2 million each year for 5 years to basic and clinical investigations. And the Hairy Cell Leukemia Foundation has increased research support for this rare disease. They also do a lot to help patients whenever they're trying to find out more information about this illness, since it's so rare. So they're very heavily committed to improving patient outcomes. This shows where the centers of excellence are located. We even have one down here in Australia, and we're working to expand the number of these centers of excellence but we have a little over 28 different university settings right now where patients can go and actually see somebody who's really treated in a very substantial number of patients with this disease. Because most hematologists will only see maybe about 2 or 3 cases throughout their career, so they don't have the same breadth of experience. So we've set up these centers of excellence, and they have to have experienced clinicians and an experienced pathologist so that we know for sure what we're dealing with. And so the Hairy Cell Leukemia Foundation has enabled us to spread the communication across the globe for people who are interested in this rare entity. This is an example of the website that we set up in, I think it was around 2009. And with the help of the Hairy Cell Leukemia Foundation, we had contributions from all of those centers of excellence so that it wasn't any one person's story. And here, Ohio State made a major contribution to this, but it involved contributions from all of the institutions. And we have information on this website that's sponsored by the Hairy Cell Leukemia Foundation for patients and their doctors. We also announce grants and support for research that may be upcoming. And this website has been extremely important. We're now trying to do a long-term quality of life study. We know we've improved how long these patients live, but the question is, how well do they live? And so we're in the process of looking at the quality of life study that's sponsored by the Hairy Cell Leukemia Foundation. And we've had many people request to participate through this website. This is an example of how sharing information can help across the globe. Several years ago, we had a request for advice about a new patient in Moscow. This patient was on a ventilator and they had both lungs involved with a fungal pneumonia, and the blood counts were very low because of the bone marrow's involvement with the hairy cell leukemia. And they were in a very dangerous situation with this bilateral fungal pneumonia. Their counts were low, the bone marrow was failing, and the doctors in Moscow were going to use cladribine for 7 days. And the problem with that, even though that's a very reasonable strategy for people who don't have infection, that can present serious complications for people who have ongoing uncontrolled active infection, because the cladribine given in such a short period of time can result in the counts going very low. So now we've educated a number of people to realize that cladribine can only be given to people after the infections are under control. But in any event, we were able to get in touch with physicians who could communicate with the doctors in Russia and tell them to transfer the patient to a center with expertise, hold the cladribine, and use this vemurafimab, which is the inhibitor of that B Raf mutated gene. Patient had a marked improvement in their blood counts and was able to get off of the ventilator. The infection was controlled, and only after the infection was controlled was the patient subsequently consolidated with this drug cladribine, and they achieved a complete remission. What was really rewarding is she came to visit with our meeting in Germany of our annual group. And then subsequent to that, she came to Columbus with her family because they wanted to see the Ohio State University, because they realized how much of a role we had all played in helping to come up with these strategies. And she sends us a Christmas card every year, and it's really rewarding to see her and her family. So you have to be careful about using these purine analogs, because they will get the disease into remission, but in addition to lowering the blood counts, it can also further suppress the immune system. So that's why it's a challenge when you take this drug, which can get patients into remission, with the side effect of causing more immunosuppression. And you have to be very careful when you add rituximab to that, if it's done simultaneously or whether it's sequentially. We're in the process of trying to decide what's the safer way to go. One of the problems, though, is after these purine analogs are administered and after people have been treated with rituximab, they may not get a vaccine response for 6 to 12 months. And so in this current day and age of the importance of vaccines for survival, we have to be very careful how we do this. There's other drugs that should be considered under these circumstances in the middle of the pandemic, and I've listed them here for you. So this is the website, and it's sharing knowledge across the globe. And we've been really pleased with the response that we've had from patients from, even though there's only 1,000 new patients here in the United States, every year. There's a lot of patients across the whole globe who call or communicate with us asking for advice. So Dr. Bronkley, Wiseman, and Downs described the clinical features of this rare disease in such comprehensive fashion that it's become a classic paper. Investigators from the College of Medicine and the College of Pharmacy collaborated with basic scientists and clinicians to actually change the natural history of this once fatal rare leukemia. We still play a major leadership role in supporting the foundation across the globe. And we've established here at Ohio State a patient data registry. We're enlisting support from a number of the other centers of excellence because we want to be able to use de-identified patient data to answer important ongoing questions. So advances in research and education for patients are supported, and we've been working with the Hairy Cell Leukemia Foundation. So in conclusion, continued efforts to incorporate new agents, new drugs, new antibodies, and strategies to increase the number of patients achieving complete remission safely are very important. And translational research based upon understanding the molecular mechanisms and targets and how resistance develops will be essential to achieving the goal of improving long-term and hopefully eventually someday cure for this disease. This is the team here at Ohio State, and I'm very grateful to them. Dr. Rogers, Dr. Bott, Dr. Blatchley are clinicians in the Division of Hematology who are experts in the treatment of hairy cell leukemia. Dr. Lizansky is in the Department of Pathology, and he's an expert hematopathologist in diagnosing this disease and separating it from the various other diseases that might look like this disease. And he's also been helping us trying to define what's the best way for looking for residual disease. Dr. Angelina and Jasmine Neal are working on the patient data registry and a number of other important studies that I mentioned briefly, particularly the quality of life study long-term. So this sort of brings me to a conclusion, but I don't think this could have happened at every university, but it certainly was facilitated by the collaborative spirit at this university and also with our multiple collaborators across the globe. And I just thought this was a sort of a neat story to tell you about the Ohio State University and the role it played from beginning to describe the disease to actually improving the quality and quantity of life for these patients. So thanks for letting me share this story with you.
Thank you. Are there any, Michael, is a fantastic talk. I'm, I think it gives a glimpse on, there probably aren't many parallels, but of all the work that goes behind, it has gone behind, trying to deal with COVID, all the different kinds of work that's done by many people to work with trying to find solutions and find solutions that have, some good outcomes. So it's a fascinating talk. Are there any questions?
Yeah, this is Doug. Can you hear me?
Yes.
Yes.
Hi, Mike. Great talk. I actually heard about Dr. Bronkley when I was a graduate student here 40 years ago. It's kind of an interesting story, and I didn't realize just how much Ohio State was in the crosshairs of this whole story. Really cool. One of the things you noticed in the very beginning was that the domination of this disease in males. Any ideas about the genetics of this disease?
No, not really. I mean, it's a shame that we don't know after these many decades, right? But there are studies going on right now. There are studies, and some of the basic scientists here on campus are actually looking at patterns of methylation in these patients. And so there are families where we have seen more patients with hairy cell leukemia than you would have anticipated. One of the I gave a talk back at the University of Pittsburgh probably about 2 years ago, and I gave some patient, no names, but just patient examples. And one of the interesting things was the one thing that they can find that does seem to have some relevance here are patients who have had a long-term exposure to farms and farming have an increased incidence. And so somebody in the audience pointed out to me, which I hadn't planned it this way, but he pointed out that every one of the patient examples I gave had been a farmer. And so whether it's exposure to chemicals that are used in farming or insecticides or whatever. There is a definite unexplained relationship between that exposure and the disease, but we don't know about any specific inherited characteristics. But there's an organization at the NIH that looks at the chronic leukemias, and we've talked to them about this. And they're interested, but they have spent a lot more time in chronic lymphocytic leukemia and the familial characteristics associated with the disease in CLL. But I think this would be another interesting project for them.
Yeah, interesting. The 4:1 ratio almost sounds Mendelian in some ways, right? Yeah. Interesting. Thank you very much.
Thank you for the
Any
question.
other questions? In the chat, a question from Mark DeBard is that I have a vague memory that the chair of IM, which maybe is that internal medicine in the 1960s and 70s, got and died from this disease. Is that accurate?
Well, I shouldn't be commenting on who had what, but it's probably known that one of our faculty members did have hairy cell leukemia, but that was, unfortunately, that was before 1980, the 1980s, because had it happened in the 1980s, we would have had something more effective to offer, huh?
Yes. Okay, excellent. Paul, do you want to ask your question or should I read it? Okay, Paul Beck has a question. Very impressive. One thing that impresses me is the international cooperation underlying the research advances. How much has the internet, Zoom, and other online technologies fostered advances?
That's a good question. The international collaboration started when the patients called us to have a meeting in Chicago, right at an airport. So it was the patients who initiated getting all these people together. And I was very pleased, that everybody responded. And the commitment that was made in 2008 to meet every year in person if possible, and we definitely want to get back to doing that again as soon as we can. But the international collaboration, when we have a tough case, I had a patient referred to me probably about 6 months ago who had a variant of hairy cell leukemia, and she was really pretty challenging. And I summarized in a non-identifiable way the aspects of her case. And I sent out over the Hairy Cell Leukemia Foundation's communication system over the web. I sent out this thing to the 28 universities. And within less than 48 hours, I had 14 responses from physicians across the globe, about what to do about her. And I think I tried to do everything, but you can't always do everything that everybody recommends. You have to put your own conclusion as to what you're going to do. But getting that help within 48 hours from experts at all these institutions was just remarkable. So I think the answer to internet communication has made a tremendous advance. The other thing I would like to add here, which is I think is really unique with this rare disease, people share unpublished data. And that doesn't always happen, unfortunately, in medicine, right? And so when you have an issue and you want to ask a question, if they have suggestions and recommendations, it's always better if they can support it with recommendations associated with data. But if they have unpublished data, they share that too. And it's been something that I've been in academic medicine for quite a while now. I haven't seen this degree of collaboration outside of this rare disease at an international level. And when we published the guidelines, for example, and when we published the guidelines for how you handle the pandemic, and we're putting together a paper right now on minimal residual disease, and we get suggestions. They're always constructive. We've never had international comments made that would be hurtful. And I mean, it's just an unbelievable group of investigators at these institutions, and they share information that hasn't even been published yet, you know, and it's respected. So nobody picks up on it and runs off and starts another study without including everybody. So I don't know how we've accomplished this, but I'm glad that it's been such a collaborative arrangement.
Yeah, that's just remarkable.
It's a good question because I'm not sure how it happened, but I'm glad it did, you know.
Okay, any other questions for Michael?
Well, I appreciate the opportunity to talk about this.
Well, seeing there are no questions, I guess we can call our meeting to a close, and I would like to thank Michael for a really fascinating talk, and I really enjoyed it. Michael, I guess I could have asked this to everybody, but when would you consider this disease completely solved?
Well, right now we get people that can be rescued, you know, from a relapse. So we hope that by continuing our investigations of these different strategies of when you add these newer agents, we're going to be able to get people, instead of having a remission that might last 5 years, or it's very variable. You know, some people relapse after 3 years, and then you know that you have to do something different. But some of them go, I mean, some of those patients that they reported from the Royal Marsden in Great Britain, they were in remission for 15 years. And, you know, you think when somebody's been in remission for 15 years that they're not going to relapse. But I have a patient right now who is on his 3rd course of therapy, but he was initially treated almost 30 years ago. So some of these remissions can be very long, and you think that you got it handled and they still relapse. So, but if you can treat somebody and get them into a subsequent remission with a durable remission, and if they live as long as they're going to live before this treatment, you know, and they die from some other cause, you know, that's considered a success. So I can't really answer your question, except every year we look at this, people are doing just a little bit better. And so it's an ongoing process, but we can't ever promise people right now that they're cured, unfortunately.
Great, thank you very much.